Hello, and welcome to today's event, The Future of Long-Term Care in Canada, an event in commemoration of the 100th anniversary of the late Honourable Allan J. MacEachen's birth. My name is Kevin Quigley. I'm the Scholarly Director of the MacEachen Institute for Public Policy and Governance. Thanks so much for joining us today. Today, July 6th, marks the 100th anniversary of Allan J. MacEachen's birth. We're pleased to welcome you to today's event honoring the legacy of Allan J. MacEachen. As part of our ongoing journey to better understand Allan MacEachen's contributions to political and social life in Canada, our focus today is on healthcare and how the sector can expand on the spirit of MacEachen's work, making it more inclusive and accessible for all. We're interested in exploring the unwritten chapters and the increasingly important issue of long-term care. Later in the event, we'll have a panel discussion addressing the challenges and opportunities in transforming long-term health. To start things off, I'm very pleased to introduce Dr. Joanne Langley, who will provide an opening address on the role of Allan MacEachen in the creation of the Medical Care Act 1966 and what his contributions mean for Canadians today. Dr. Langley is a professor of pediatrics and community health and epidemiology at Dalhousie University and the Canadian Centre for Vaccinology in Halifax, Nova Scotia. She's also the co-chair of the Canadian COVID-19 Vaccine Task Force. Dr. Langley, thanks so much for joining us today. Over to you, Joanne.
Thank you so much, Kevin, and thank you so much to the Institute for inviting me to participate in this event commemorating the Honourable Allan MacEachen and consulting on this very important Canadian issue. How do we best serve those citizens who cannot live independently in their elder years? Today, I'd like to speak a little bit about the impact of COVID, share some reflections on what we've learned, and close with a few ideas about this towering figure, Mr. MacEachen, and what we might learn from his work with Medicare. This is called In America, How Could This Happen? It's a project by artist Suzanne Furstenberg. There's a flag planted for each death, and as the death toll increases each day, more flags are added. This is not a work of art. It's an aerial photograph of a graveyard in Brazil, the town of Manaus, where SARS-CoV-2 virus, which is the cause of COVID-19, spread unchecked. And I think it can be argued that this was in large part due to the unwillingness of the government to introduce systematic public health measures that the population could obey. The anguish on the face of this healthcare worker in Spain at the funeral of a nurse captures the profound sorrow of the last 15 months. While no part of humanity has not been touched by this pandemic, older adults truly carried the heaviest burden in terms of death. In this slide, we see COVID-19 deaths in Canada according to age and gender. The darker blue is male. So on the top left of your screen, we see the youngest population, 0 to 19-year-olds, who had the lowest mortality rate. In fact, there were only 14 deaths, all important, of course. At the bottom of the graph, among persons 80 years of age and older, there were 16,000 deaths. In fact, 81% of all deaths in Canada during the pandemic so far have been in nursing homes. In this slide, we see a common media picture that we have seen during the pandemic, where isolated persons in long-term cares were separated from their families, often dying without their families. The pandemic exposed deficiencies in the care of older adults who can't live independently, and our experts on the panel will dive into those specifics and how we can improve care. I'd like to share some personal reflections about what I've learned from COVID using the example of vaccines. And those are what I've seen in terms of the power of collaboration, the power of institutions to act for the betterment of communities, and the finding that we need to combine country-level sustainability and preparedness with the recognition of our international interdependence. This graph illustrates the timing of federal, provincial, and territorial interventions to prevent SARS-CoV-2. And this is on the CIHI website. It's free for you to interact with. You can open the places where there's pluses and explore it and look at your own province. I will focus right now on vaccines. And you can see the categories there are implementation, phase changes and milestones, population to be vaccinated, purchasing and allocation, and regulatory approval. I've been working in vaccine research and pediatric infectious diseases for 2 decades, and never before in human history have we conducted research on and scaled up vaccine manufacture as we did during COVID. To me, it is truly amazing that on December 16th, 2019, the index case was identified in Wuhan. On January 9th, the viral genome, the identity of the virus, was shared on on 2 open access websites for all scientists in the world to get access to. And then within months, we were starting large randomized control trials. This truly set a new standard of what humans can do when they make the resolution of a problem their priority. Between pandemics, immunization programs in Canada run a little differently than they do during a pandemic. On the left, you see the schedule for Nova Scotia for children, youth, and adults, and the schedule looks a little different in each territory or province. So usually a vaccine manufacturer submits an application for approval, the regulator approves it, there are recommendations made, and provinces actually decide what vaccines they want to use and how to implement them. For pandemics, since the 1990s, we've had in place a pandemic influenza contract at the federal level. However, no one anticipated a coronavirus pandemic, and so there was no stockpiled coronavirus vaccine when the pandemic started. Hence, the government put into place the COVID-19 vaccine task force, which was established in June to have with an overarching mission of securing safe and effective vaccines for Canadians. I have been very fortunate to serve on this task force and really witness the power of whole of government responses, where there are collaboration across all ministries and dedicated and skilled public service members who, from all I can tell, work 24/7 at all hours of the night to mitigate this threat across many, many areas of endeavor, vaccines being only one. Our goal was to look at domestic candidates, so candidates that might be available to manufacture in Canada, international candidates, and biomanufacturing strategies. And ultimately, as you know, no Canadian domestic candidate was quite ready to be used as quickly as the international ones. And we learned a lot about what we need to do to build back our biomanufacturing. Ultimately, advanced procurement agreements were made for 7 vaccines with over-procurement in case some failed. And not only that, but the government had to figure out how to deliver these vaccines. So 322 -80 freezers, dry ice from 6 companies, kilos and kilos each week, and so on and so on. It is a huge endeavor that really only a government can take on. The provinces and territories have rolled out programs, not without difficulties, as we all know. But now we stand in this enviable position with Canada up there at the very top in green, as having in the world the highest percentage of people who have received 1 dose of vaccine. And there's still work to be done. This is a 2-dose schedule, and we need 2 doses for duration of immunity and for full protection. And there are many people who haven't gotten their first dose yet. And we need to find out if that is due to inadequate access or concerns about safety. Whatever the problem is, we have to figure it out. We also can lift our gaze now to the world, where most of the world's population has not received any vaccine. Now, why is this important? Morally, it makes sense that we would want all the peoples of the world to be protected. But very practically, control of infectious diseases and many other problems, such as climate change, require a global perspective. These are just some of the new or reemerging infectious diseases that have been identified since the 1980s. It's truly stunning. And it's thought that some of these are due to climate change, other are due to the migration of people, travel, changes in environment, urbanization, and so on. But we clearly need a global perspective as well as country level sustainability and capacity to protect our peoples. So as we make our way through and out of the pandemic, I suggest that we can learn from our experiences, the passage of the Medicare bill, the struggles we've had in COVID and how we've overcome them, to tackle the problems that have been there all along, but now we understand them better. They're really just manifested to our eyes. And long-term care is a key one. And with Mr. MacEachen's example, I think we know now, as we did with vaccines, that we have the capacity to tackle tremendously difficult problems with patience and perseverance, however long it takes. Thank you so much.
We now change gears and shift to our panel on long-term care in Canada to extend the discussion that Dr. Langley's opened. I'm pleased to introduce our moderator for today's panel, the Honourable Anne McAllen. Anne McAllen is a senior advisor at Bennett Jones. Before joining the law firm, she enjoyed a distinguished career in federal politics, including as Deputy Prime Minister of Canada, as Mr. MacEachen was, Minister of Public Safety and Emergency Preparedness, and Minister of Health.
Thank you so much, Kevin, and it's a great pleasure to be with you. And let me say that I'm honored to join my former boss, the Prime Minister, Jean Chrétien, and my dear friend, Darrell Dexter, as fellows of the MacEachen Institute. Let me just share one brief story of my own with Allan J. MacEachen, since today's his birthday. When I showed up in Parliament in 1993, October 1993, Allan J. MacEachen was a senator. And Allan J. was treated with the reverence and respect in Liberal caucus every Wednesday morning that you would expect. But Mr. Chrétien gave me a very tough job. One of my jobs was to phase out federal involvement in coal mining in Mr. MacEachen's beloved Cape Breton. And Mr. MacEachen and I had many vigorous discussions, as you can imagine, sitting in the back row of Liberal caucus while he explained to me why maybe that wasn't the best idea, or if it was an idea, how I should actually go about doing it. And I will always cherish and remember those discussions around that particular challenge with the wonderful and, as I say, highly regarded Allan J. MacEachen. Today's panel is entitled Long-Term Care in the Canada Health Act, the Unfinished Chapter, ? Arguably, this chapter has not even begun to be written in the context of the CHA, and an important question is whether we should even try to write that chapter in the Canadian or Canada Health Act, or whether there are other mechanisms by which, as a society, we can create a better quality of life for those needing long-term care. We all know that long-term care has been discussed and analyzed in this country for decades. Demography has told us all that as we boomers age, and I'm one, the demands for long-term care would increase dramatically. When I was Federal Minister of Health some 20 years ago, we worked on one piece of the continuum of elder care with the provinces and territories, and that was home care. But only with limited success. Overwhelmingly, we hear from seniors that they want to stay in their homes and retain their independence for as long as possible. What do we need to do in our continuum of care to make that possible? But sooner or later, many senior Canadians will require long-term care. How do we avoid the tragedy we saw play out during COVID, where the vast majority of deaths were residents of long-term care facilities? Governments, healthcare providers, families, all of us have expressed our outrage at this tragic reality. But how do we take this outrage and make changes that ensure those in long-term care and their families know that care is delivered in high-quality facilities with appropriately trained healthcare workers and other required supports? Because of COVID, is this a focusing moment, a galvanizing moment for governments, for all of us? Is this the moment in which meaningful change happens? Let's turn to our outstanding panel to get their perspectives on this societal challenge and how we can all move forward together. Our panelists each have been given 4 minutes in which to make their initial remarks. And first, let me turn to Dr. Samir Sinha, a well-known voice on our elder care system in Canada and currently Director of Geriatrics at the Sinai Health System in Toronto. Over to you, Samir.
Thank you very much, Anne, and it's a real honor and privilege to be here today, just to really talk about, what have we been thinking about when we think about long-term care? I think we've already heard from Dr. Langley and just in terms of how this pandemic has really made us focus on this area and how we think about older Canadians. Just repeating some of the stats we already heard, 95% of the people who've died in Canada during this pandemic so far are people 60 and older. Right now, at the very beginning of the pandemic, 80% of Canadians who were dying in our long-term care and our retirement homes. That number has come down over time to now 58%. But just to put that in perspective, that's twice the international OECD average. So it's important to realize that when we saw such a strong signal of where older people were dying, in particular in our long-term care homes, it told us that there were some things that were fundamentally wrong. And I think when we go back, when we start hearing and start looking under the hood and saying, what's going on? Why are we seeing such outbreaks and such death in our long-term care homes compared to other settings like our hospitals and our community settings? We realize that what Canada has is a patchwork system of provincial and territorial-led long-term care systems that were never included as part of our Canada Health Act and largely are simply underfunded. When you look at Canada as we compare against the rest of the world, when you compare us against the OECD nations, for example, we spend 30% less of our GDP on providing long-term care than the average industrialized nation. We spend half of our GDP providing long-term care as a country like Denmark does. And then when you start looking at that data in comparison, you realize that poorly funded homes, where we don't provide enough funding to provide the care in the homes, it means it's a recipe where you can't retain staff, it's hard to provide good quality care, and then when COVID hits, it's just a recipe for a disaster. And so that's the question. The question that we're starting to think about today is that how do we move forward? How do we actually think about how we need to move forward? Because we know it's not just better quality facilities, but it's actually making sure that we're funding the appropriate amount of care in these homes. But do we need to do that through the Canada Health Act? Do we need to do that through legislation, or is this something that that each province and territory can do? And I think this is the problem, because if we think back to the great work that happened in 1966 to create the forerunners of the Canada Health Act, our Medicare Act, if you will, I always say that that was our original sin, because while it was tough to even pass this act in the first place, the average Canadian at the time was only 27 years of age. Most Canadians didn't live beyond their 60s, and so long-term care was an afterthought. So was pharmacare, and now these are two of the cornerstones that we need to think about as we move forward. So finally, as we start thinking about the future, is it about reopening the Canada Health Act, or is it actually about pursuing new national long-term care standards? One of the tasks that I've had over the past year, in addition to trying to think about and understand what went wrong as I've been studying the long-term care system and just the care of older Canadians in general through both my clinical work as a geriatrician, but also as a person interested in policy and strategy around older people in long-term care, is that we need to think about how we can move forward in a systemic way. We need to think about the funding disparities that we have as a country as a whole. It's not a Nova Scotia thing, it's not a Manitoba thing, it's a Canada-wide phenomenon. We need to think about how we can look at new national long-term care standards, but perhaps ones that are either accepted by the provinces and territories, or also kind of codified by our federal government as maybe a way forward in terms of saying, what do we think that quality of care should look like, not just for people living in long-term care homes, but how do we better support Canadians to age in their places of choice with the right care in the right place at the right time, so that people are able to age where they need to be and get the right care in the best ways possible. So I'm going to stop there and pass it back to Anne so that we can hear from our other panelists as well.
Thank you so much, Samir. And next, I'm going to Dr. Gaynor Watson-Creed, a familiar face, I think, to many people in Nova Scotia. She is the former Deputy Chief Medical Officer for the province of Nova Scotia up until April. And now she is Assistant Dean of Serving and Engaging Society at Dalhousie's Faculty of Medicine. Over to you, Gaynor.
Thank you so much for that introduction, and also to the comments that have been made so far by Dr. Langley and Dr. Sinha. Mine are going to be fairly similar, and I'm going to start actually, Anne, by answering your question around, is this a galvanizing moment? I think it is, and those of you who have heard me in some of these post-COVID or emerging post-COVID conversations have heard me refer repeatedly on a different front towards the value that I think is there in federal legislation as a galvanizing tool in a federated nation like Canada, and that capacity to sort of hold provinces and territories to account on deliverables and expectations from our publicly funded healthcare system. Having said that, as a public health physician in Nova Scotia, it's interesting, my career here over the past 16 years has included engagement with long-term care facilities, but largely around outbreak management, specifically around outbreak management. And what I find interesting about that as I reflect on it now is that where we've not gone in Nova Scotia, many other provinces have, and I think we will in Nova Scotia, is into the broader conversations around what that long-term care population is that needs our attention and our support as public health. And to be clear, public health practice is the practice of what we call population health or population health medicine. It's that idea that we're looking beyond the individual and what may be making them sick to what has the potential to make an entire group sick. And that can be communicable diseases, but it can be a whole host of other things in the environment. And so when I think about what those other things are, particularly in long-term care facilities and our opportunity to reimagine long-term care facilities, I start to think about what was the galvanizing sort of idea that brought us to the creation of long-term care facilities to begin with. And so if we ever had a notion around this, it may be lost, because certainly what I've seen in my career has been this sense that long-term care facilities exist as a resource to community, but largely to the healthcare system that feels burdened by the care that is needed and the very in-depth care that is often needed by the frail elderly, forgetting that frailty is actually not necessarily a given end state of aging. And our population statistics around that are actually quite clear that 25% of Canadians over the age of 65 actually meet the criteria for what we would call sort of medically frail, and what we would think of typically as having those conditions that need that intensive care. It rises to 50% in populations over 85. And so the statistics that both Dr. Sinha and Dr. Langley have mentioned, I think are germane. But we have a whole host of aging Canadians who, as Dr. Sinha has pointed out, have a desire to age in ways that respect and reflect them. And so I start to wonder if in some of our debriefs and reviews and considerations of long-term care going forward, if there isn't something beyond the resourcing, beyond the need for funding, all the other gaps that are there, that is about fundamentally what is the cultural need that we need to step into to support these communities to thrive. And I think we forget that thriving and aging can go in hand, as well as what else we see when we come to aging. And so in the lead up for this conversation, I sort of did some literature digging and found this really beautiful article from 2001. So this is not new thinking. In the Gerontologist, where it describes a quality of life approach to designing and developing long-term care. And the domains that are described as being of highest importance include security, comfort, meaningful activity, relationships, enjoyment, dignity, autonomy, privacy, individuality, spiritual well-being, and functional competence. And so I don't know if you could write all of those things into a Canada Health Act, but I do think that there is some merit to us looking at our long-term care facilities with a lens that is broader, that is around well-being, and is actually around supporting communities to thrive, rather than thinking of these as communities that need to be managed in such a way that they don't add additional burden to the healthcare system. If we had that type of thinking in place, I wonder if it would change our approach to communicable disease transmission and how we handle that. I wonder if it would change our approach to how we think about the family members who are often the caregivers in community and what their role needs to be now in these communities that exist. I wonder if it would change how we fundamentally design those communities to support those qualities of life being. So when I think about the future of long-term care, for me, I think we're at risk right now of overlooking some of those cultural underpinnings, principles that need to be in place in favor of looking at what we traditionally look at, which is the resource needs and the funding needs and all the rest. And while I think that's there and that's needed, I think we've got a great opportunity to look at the other as well. So I think that's where I'll end my comments and throw it back to you.
Great. Thank you so much, Gaynor. Next, I'm going to Jason Shannon, and Jason is President and Chief Operating Officer of Shannix, a provider of elder care through what I describe as the continuum of care. I believe, Jason, primarily in Nova Scotia, New Brunswick, and Ontario. Over to you, Jason.
Thanks a lot, Anne. Appreciate being part of this conversation. Never more than right now, having been in the service of seniors for over 20 years, is this conversation more important. Obviously, it's been a tragic year for a lot of families and residents having to deal with COVID, but we have to make the most of the situation. And not only for nursing homes, but clearly seniors care is a critical part of the entire community health program that we have across Canada. A well-functioning nursing home service makes our home care partners better. It makes the acute system work better, and we need everybody to deliver on their commitment. Our family has had the privilege of servicing seniors for over 32 years, and we fully support a review and consideration of national standards, especially if it's going to include the families and the residents who live and work and participate in long-term care. We're very grateful. One of the residents that live in one of our homes today is sitting on one of the committees of the national review, so that's great. But, having been through COVID and been really at the front line of several outbreaks that happened during the second wave, my understanding more than ever is the role of the frontline employees is the most critical part that we need to focus on, in addition to standards. Although there was so many tragedies that happened across Canada, there were so many great things that our frontline caregivers were able to work through, showing really resilience, passion, expertise, and support for the residents and the families when they couldn't be there. And really coming into the pandemic, we really understand that they are the true heroes of the story. But we need to do more. We need to do more for these workers. And home care has been a wonderful support. And you referenced it earlier, Anne, some of the work of the federal government. And really the home care budgets across Canada have grown exponentially over the last 20 years. And when you think about someone coming into long-term care, in most instances today, they're coming in after having used up 4 to 6 hours of care per day at home. And during those same 20 years as operating these homes, it's embarrassing to say, but some of the staffing levels we have today in our budgets are the same as they were 20 years ago, really before home care was funded to the extent that it is today. And I think, that's one of the challenges that we saw through COVID is we need more staff. We need a different complement of staff. And it's not that home care has been anything but a great thing for Canada. It's just when we made the changes in home care, I think we probably failed to realize the impact that it would have on the rest of the system. Clearly we may have to make investment in technology. training and development. And, if we're going to get a next generation of workers to come into long-term care, those are areas of the budgets that have not been supported. And, operators need to step up and figure out how to make that part of the conversation when we're moving forward. And clearly we need to think boldly. And I think, when the conversation today about the Canadian Health Act, I've been around long enough to see some of the changes that have happened in long-term care. And generally speaking, across Canada, the healthcare portion of long-term care became an insured service almost universally across Canada around 2005. And today, whether you're private, for-profit, private, not-for-profit, we all operate under the same tenets, which is, the healthcare dollars in long-term care have to be spent on healthcare. And if they're not spent on healthcare, they go back to government. And, I think we have to build on those concepts. I think another thing that we need to do is, I think national standards have to be woven into provincial standards. It's not likely the provinces are going to give this up under the constitutional framework that we have today, but I think they can work together. And, I think they have to work to gain the public trust. I think we have to increase transparency. I think the nursing homes and almost all provinces across Canada now are committed to public reporting of all quality indicators through CIHI. I think we have to make that a priority because we have to gain the public trust back in long-term care once we make some of these changes. And, I think also Accreditation Canada, we've been an organization accredited under Accreditation Canada since 1993. There's probably a role to play there. All hospitals in Canada are accredited. For nursing homes, it's voluntary. And right now, there's probably less than a third of homes actually are accredited. So I can see a future where, there could be national standards. They're part of Accreditation Canada, but they're also woven into provincial standards. So operators have to meet both in a world where we can have increased transparency with public reporting of all your quality indicators. So thanks, Anne, for allowing me to be part of this conversation today.
Thank you very much, Jason. And I think you've raised a number of important issues that will probably come back in the questions and answers. Over to our last speaker on the panel, a man who probably needs no introduction, at least to any Nova Scotian and many Canadians. That is Darrell Dexter, and he is obviously the former Premier of the province of Nova Scotia and now Vice Chair of Global Public Affairs. Over to you, Darrell, to that cleanup, I guess.
Yeah, well, thanks, Anne. So I'm going to try to tie some of these things together. As Dr. Sinha mentioned, long-term care was not included under the Canada Health Act, and it did grow up, in fact, in a kind of multi-jurisdictional way where each of the provinces and territories grew its own system. There is a federal funding envelope for veterans. That means there's almost a separate other system out there. So really more like 14 different systems. But even within the provinces, they grew up in a very haphazard and ragged way. Oftentimes it was local communities who saw the need, and it was either through not-for-profits or charities in some cases that set up initial long-term care facilities. Sometimes it was municipalities. And in our province, in Nova Scotia, the long-term care sector was not even in the health budget until the mid-2000s. In fact, it was maintained through community services. And that was because long-term care costs were actually borne by the individual, by the private citizen, and the provincial government did not step in until a person would become impecunious, unable to pay, and therefore the funding was seen as part of this kind of community services model. Now, fortunately, that, as I say, changed in about the mid-2000s. It was moved over into healthcare, specifically for the healthcare component that was being delivered in long-term care facilities. And the argument at the time, which I remember very well, was that the health services, just because they were being delivered in an institution that was not a hospital, did not make them not healthcare services, and therefore should be fully insured services. So that's kind of how that migration took place. Look, I agree entirely. I think Jason said this. I think maybe all the panelists said this. National standards are absolutely imperative, but along with that comes the very important aspect of the partnership that the federal government has currently in the Medicare system and needs to have in the long-term care system, and that means, some serious allocation of funding to the provinces from the federal government. That includes two things. I think it includes a bulk transfer that would recognize the fact that the systems have already been built by the provinces, and that came with a considerable cost. And secondly, yearly transfers that recognize that this is going to be an ongoing healthcare budgetary item for the foreseeable future. Also, in addition to this, the standards is the question of what principles underlie the standards that are going to be put in place, the system that's going to be put in place. And I would argue that those principles need to be the same principles that underpin the Medicare system. So it needs to be comprehensive, universal, portable. All of those principles that we are familiar with respect to Medicare need to be applied to long-term care. The last point that I'll make is this, is that long-term care facilities, I think Jason said this, he's seen the changes that have taken place over the years. There have been enormous changes. And one of those changes is the fact that the acuity rates that exist in long-term care facilities today are far higher than they were 20 years ago. And they are going to continue to rise. And that is going to put a much greater strain and burden on those facilities, on the workers who work there, and they need to be paid appropriately for the burden that they're going to take on for the benefit of all of us. And with that, Anne, I'll turn it back over to you.
Okay, I want to remind everybody, send your questions to the Q&A function. It's interesting, we have one comment from Kevin McNamara, who, and I think we've heard from all of you, all four of you in this respect. He says, among other things, from government, we need good standards and holding facilities accountable to those standards. And then Dr. Sinha responds, 58% of Canada's long-term homes are accredited against the current national LTC standards. To Jason's point, it should be 100%. Okay, so if this is a galvanizing moment, all of you, how do we get the remaining 42% of these long-term care homes? How do we motivate provinces to say that, one, to adopt national standards and the federal government will want to attach some conditions, as I believe as a former federal politician they should, although Darrell and I might disagree, but how in fact do we get the provinces to accept national standards and then get the provinces to actually hold long-term care facilities to those standards? Who wants to go first? Darrell.
Yeah, so I'm really happy to respond to this because I think it is, a very important issue. But one of the things we have to recognize is just the age of the infrastructure that exists in the various provinces across the country, and that's a fundamental problem here in this province. And we the new facilities, the facilities that were built kind of after the 2010 thereabouts, those facilities are excellent. They meet the highest standards and are I think capable of delivering the services that need to be served. But there are many that are decades old. And in order to allow them to be able to meet the kind of standards that would be imposed upon them through national standards, there needs to be a significant amount of money. And that's what I was talking about when I talked about a lump sum transfer that needs to come to the provinces to be able to support that kind of infrastructure. And we saw this pretty starkly here in the province of Nova Scotia in terms of what happened during COVID. And a lot of that was related to the infrastructure.
Anyone else? Dr. Sinha, you've talked quite a bit about this on national television and elsewhere.
Yeah, this is a tough one, right? Because you look at some provinces and territories that have been, good citizens, I will say, and have continued to upgrade, their facilities, make their own investments and do good work. And then let me pick on my own province right now. It's not my home province of Manitoba, but my adopted province of Ontario, where 30% of the beds are built to 1972 design standards. We're talking about to redevelop and build, 30,000 new beds, we're talking about $8 billion. Right now, the federal government has put $3 billion net new dollars on the table to try and help enforce long-term care standards. And all of a sudden, if we try and fix Ontario's deficit because it's neglected to redevelop those beds, well, Nova Scotia, you're out of luck. So the question becomes, how do you do this practically? And I don't think, one of the concerns that some provinces have is we don't want this imposed on us when frankly, you're not actually paying for this. So if you impose what you want, but pay for it too. So if we don't move to that, is there a mechanism where we say, well, if Nova Scotia wants to, further invest and meet these new standards that we actually have, then there's money that can be given to you to, out of this new 3 billion, 4 billion to actually help Nova Scotia do that. But it's how do you actually get everybody moving forward, in a fair way that doesn't mean that Nova Scotia is paying for Ontario's sins, if you will, when parts of Nova Scotia or Jason and his group have actually been going above and beyond by accrediting, looking to develop excellent care where you can't say necessarily that everybody else has.
Jason, let me ask you, 42% of your fellow providers of long-term care in this country are not accredited. When you sit around those tables, what do you hear? Why aren't they accredited? Are you and others like you who are you putting pressure on those who aren't to say, guys, we're all getting a really bad reputation here. Some of you need to step up your game.
I think there are a couple of different organizations out there that do accredit nursing homes. Accreditation Canada probably is the most universally recognized, and it's not a part of the federal government, but certainly connected to the fact that they're accrediting hospitals. So from my vantage point, they probably have the most credibility. Listen, I think it's starting. The conversation and, coming out of waves 1, 2, and 3 have been very difficult. The operators have been working very hard, and I think the conversations are starting. What we need to do as a sector, what we can do together. But to Dr. Sinha's point, not all operators are probably, focused on the right things. So some of it might have to be put in place by the government. And, I think there's a framework there that we can build upon. I think constitutionally, I think we have to be careful on where we start the conversation, because I don't think the provinces will give this up, because there's been lots of discussion over the years on that. And I don't think that could be a waste of time. But I think attaching funding from the federal level to the national standards could be a way of doing it. And I think that'll make people come along. But I think it's probably not going to be voluntary is probably not going to be the way that's going to happen. It'll have to come through, funding and a requirement, just unlike the hospitals are required to be accredited.
Dr. Gaynor, I was struck by what you said that we should take a look. Sorry, Dr. Dr. Gaynor.
Okay. Yeah, Gaynor. Dr. Gaynor works.
Sorry, double barrel name, Gaynor. If
yes.
you don't mind, I'm just going to call you Gaynor.
Yeah.
But you actually made a really interesting point about looking at this with a wider lens, the cultural context, and that context speaking directly to the quality of life in long-term care. I think many Canadians would say that some of the pictures we've seen were more like warehousing, right? Unfortunately, during COVID, that these were not places that had thought about culture and what they wanted that culture to be as it related to quality of life. How do we get to where you want that wider lens to be?
Yeah, well, I don't think it's that far from the conversation that we've been having about how do we get to the standard setting table, regardless of where those standards come from. So whether they're standards around health human resource capacity or, capacity related to other forms of the infrastructure, or this question around what's the culture. I think a lot of it comes from standard setting, and I wouldn't want to dismiss the idea of incremental standard setting or incremental approaches to standard compliance being not okay here. I think when you're dealing with the size of the infrastructure challenge that Mr. Dexter has outlined, and he's right to outline it, incrementalism is sometimes the only place that we can go. But it can be helpful because it allows folks who have the capacity to do that early adoption to show the others what's possible. And provided that the funding carrots that Mr. Shannon has laid out are there, and the requirement is there, others can follow. So, you know, I think it is possible through standard setting. I think what we would have to do is make a commitment to lay out those standards around quality of life frameworks, in addition to the standards that we would lay out around infection prevention and control and environmental health and air quality and all the rest, right? But I think that can be done. So I have some hope for that.
Anybody else want to contribute to that point? How do we build that culture? Dr. Sinha, Samir.
Yeah, well, I think, you know, Barbara in the chat also kind of raises this point that Dr. Watson-Creed, you know, eloquently said earlier as well, that facilities are institutions rather than desirable home-like care homes. You know, how do we make that transition? And I think it really starts with thinking about, you know, again, why do people, if, you know, in a community, first of all, how are we equipping communities to provide, you know, the best support for older adults where they want to be? And during this pandemic, we've seen that, you know, upwards of 70% of older Canadians have said they've changed their mind on whether they'd even want to consider moving into a long-term care retirement home in that way. And so a lot of Canadians have lost a lot of faith kind of in this form of care. And I think it starts broadening those bigger questions. What does good care look like, right? And I don't think people talk about the size of a room. They certainly don't talk about, well, I mean, people do talk about the food, but I think people actually talk about being treated like a person first. They talk about resident and family-centered care. I put a link into our National Long-Term Care Services standard survey. We've had over 8,000 Canadians respond so far. And just like what Dr. Watson-Creed said beautifully, right? It's about quality of life. It's about being treated like a person. It's about being in a home-like environment. It's making sure that we understand how do we actually deliver excellent quality care, but also I think there's an opportunity, you know, here not only to think about what are those standards and how do we actually articulate what Canadians want, and then how do we get there? And again, we have leaders across the country who are delivering exceptional care, incredible staff delivering exceptional care every day, but also thinking more broadly, why is Canada spending 87 cents on every long-term care dollar about caring for people in institutions rather than in their own homes, where if you look at the OECD average overall, you know, much higher proportions of spending are being used to keep people in their own homes where they want to be. So I think there's some broader questions here, but I think this is kind of that framework of how we can look to again, thinking about what long-term care standards should look like, and then how do we move towards that as well.
I see someone has raised the question a few years ago. Is this you, Gaynor?
Yeah, it was me, and yeah, just making an additional comment.
And I think that's actually a good question. It probably didn't change very much, did it? But one of the things I've been reading about recently, because we look to other countries for guidance, this notion of cash for care benefits that other countries, I think Denmark and some others, and maybe many European countries, I don't know, seem to be putting in place. And it's direct public transfers from either federal or provincial governments, Darrell, to long-term care recipients or their caregivers. And that could be a family member, or it could be Shannon's, I would think. So what do you think about, and Dr. Sinha, you probably know quite a bit about this based on your research, this kind of new mechanism called cash for care benefits. Would this work in this country?
I can take a stab in terms of at the first point. I mean, I think the bigger issue that we have is that when you think about cash for care benefits, for example, I think this works well when you have something like a national long-term care insurance scheme. So the challenge so in a country like Germany, for example, if you qualify for long-term care, then you qualify for a certain budget or a package, and you can choose to use that, you know, for its government-funded home care, or you can just buy your own home care, or you can choose to live in a retirement home. You can actually use your budget in the way that would work. The challenge is that when you think about older adults, frail older people and their care, it evolves so quickly that sometimes it's hard to say, if this is the budget you got and then you blew it, you know, and not because people were irresponsible, because you didn't expect that someone would have a heart attack and now have these changing needs, then how do you make sure that people are best supported? So cash for care, or this notion of direct funding, works really well for certain populations like medically complex children or adults, for example, who have more stable long-term care needs. It's a bit more tricky, but I think the more fundamental issue is we don't actually have a national long-term care insurance scheme. So the average Canadian retiring right now without a workplace pension plan is retiring with $3,500 in the bank. So let that sink in, because imagine now, if you don't, beyond CPP, old age security, guaranteed income supplement, if you only have $3,500 in the bank and you've just retired, that ain't gonna buy you much of anything. And so the question is, and then whatever we have left over may not be adequate to meet your needs. So I think we need to fundamentally rethink, just like we've done with Medicare, how do we think about long-term care when we don't know who will need what in the future?
Darrell, do you have any views on that?
Yeah, there's actually a lot to unpack in what Dr. Sinha said and what Gaynor said. And it's hard to parse it sometimes, but the reality is that the quality of care that people receive at home, if that's able to be supported, I don't think there's really an argument that says that isn't a higher kind of quality of life, because it's far more, in most cases, it's far more comfortable. It's what they're used to. It's surrounded by their loved ones. It's just that does not displace the need for long-term care, because there becomes a point where the services that are needed by that individual are just not capable of being provided for them in that setting. And so you need to have a long-term care home system as well. And I also don't want to leave the impression with people, because we talk a lot about institutions and warehousing seniors. I don't want to leave the impression that that's anybody's intention, because in many of these long-term care homes, there's a myriad of programming that takes place within those institutions that is designed to provide support, help, all of those kind of cultural aspects of people's lives. There are music programs, there are exercise programs, there's a lot of times they're designed by the facilities, but there are many things that happen in those facilities that are designed to create a sense of normalcy, of comfort, of spiritual well-being that take place within these facilities, and that shouldn't be forgotten.
And Jason, just doing a little research for this, I noticed that at Shannon you have resident directed care. So I would think that speaks to the fact that you are involving your residents in what they want to see in terms of quality of life issues.
I think that's a good point. One that I was going to make as well. When you look through the last couple of accreditation cycles, the focus on resident and family directed care has been a big push. And I think it's around choice. And, I think that's where we're seeing the best outcomes when they participate in the decision making. And I couldn't agree more with what Darrell just had to say about, life in nursing homes. I receive hundreds of letters a year from families that are, feel blessed that they're getting such wonderful care. I mean, there's lots of great things happening in nursing homes, so we can't forget that. And there's thousands and thousands of people that get up every morning and work so hard to provide quality of care, and it's happening across the country. I think what we need to do is recognize that there's been a lot of system change. The frailty of people coming to long-term care has changed radically over the last 20 years. And I'm telling you, the standards of funding have not kept up. And so, there's a lot of operators trying to do what they can with the resources they can, but we do need to resource nursing homes better, because they're going to play a critical part of keeping the acute system working better and allowing home care to work better. When you talk to home care operators, when they have to go in and provide very complex 24-hour care, they're spending a lot of their time when they could probably be much more successful providing home care to people who need the 2 to 4 to 6 hours. And so, we can't forget that either. So hopefully this conversation will get to the people who matter, and that there'll be real change and in the way we're looking at long-term care. It's a critical part of our services in our community, and people deserve better. And so I think everyone's at the table right now, and hopefully we'll make the best of this.
Indeed. And I think that's a good note on which to end, because I see that our time is up. I think this is a subject that we could talk about for many, many hours. I mean, certainly all of you on this panel are experts in this area. I am not. So I want to thank you all for being here today.